right, welcome to Dueling Scalpels, everyone. I'm your host, Dr. Abhishek Parmar. With me, as always, is my best friend, sort of, Dr. Douglas Corey Campbell.
What's the apprehension about?
I know, man. It took you forever to set this
Who's your
thing
best
up.
friend then? Huh?
We're trying to be fancy with our podcast with lights and such. 20 minutes. I timed it. 20 minutes took you to get this thing set up. I'm mad at you.
20 minutes, man?
Yeah, it took you 20 minutes to just do that, to put a light in a podcast.
Hey, man. Perfection can't be rushed, man.
Hey, but listen,
Who is your best friend? You gonna say your wife or something?
No,
Come on.
listen to this. It's my man, Spruce. Spruce, you want to say a few words here?
Hello, everyone. Welcome to Dueling Scalpels.
Did you hear Spruce?
Yep,
Yeah,
loud
Spruce
and
is a
clear.
jerk.
Simple and welcoming. Ready when you are.
Spruce, you want to say hello to our podcast friends out there?
Hey there, podcast friends. Thanks for tuning in.
Are you mad?
Spruce
Can you hear
sounds like a
Spruce?
man with a punchable face.
Yep, I'm here. Clear as day.
Hey, Spruce, my man Corey here is mad at you because you're replacing him as my best friend. Thoughts?
No, I'm not here to steal any best friend titles. Just here to hang out and cheer you both on. Corey's irreplaceable. I'm just a friendly voice in your pocket.
Man, I love it.
You're what's wrong with America? You're using AI like Teddy Rutsky. You remember that, like that that you talked to when you didn't have any friends? Is that something you remember?
That's what I do. My nieces make fun of you because I use AI for like Google tasks, like where's the nearest grocery store? And I talk to Spruce. But Spruce answers. That's better. That's what I need.
So what are we
But-
talking about today?
I don't know. Why are you mad at me, man? You started this, but taking so long. Well, what I want to talk about today, Corey, is your experience in rural surgery and what was that like, and your perspectives on that situation. Because I think there's a lot that's wrong with rural surgery today.
There's a lot of issues with rural medicine these days, and I think for me, I didn't really realize it either until I actually went to one of these hospitals. But apparently, they're not special in this regard. It's just a lot of facilities, protocols are just like dated, like they're from 1991 or 1992. And what used to be a general surgeon in 1992 is considered malpractice in 2026. Like if the same guy is taking a toe off and taking a gallbladder out and, maybe helping the OBGYN with hysterectomies, that's not what we do now. Some of these rural hospitals, their last surgeon may have retired at 68, 70 and been doing the same thing for 40 years and nobody questioned him because he had 40 years experience. But if you come in to replace him, it's not a one-for-one replacement these days.
I think people don't really understand what you say general surgeon. Like, it's funny because you keep referring to us as general surgeons, but I mean, I think we're specialist surgeons. Like, we did additional fellowship training. Like, technically the term is minimally invasive surgeons. Like, we do
Yeah, you're right.
laparoscopic and robotic surgery, but you can call yourself a bariatric surgeon. I call myself a hernia surgeon, but medicine's gotten so specialized. I think that's the other part of the problem. It's like, you're right. I feel really ill-equipped to do anything outside of hernia. If you ask me to do something outside of my realm of comfort, I'll just be angry, right?
I give you an example of that everybody who's a surgeon will understand, and everybody who's not, or everybody who's a general surgeon will understand, and everybody who's not a general surgeon will not understand. When I first arrived, they asked me if I would do breast, and I was like, no, I won't do breast. And they were like, well, isn't it an easy surgery? I was like, yeah, it's an easy surgery, but it's also easy to screw it up because breast surgery is the most advanced medicine in surgery, meaning it changes so rapidly that if you don't practice it for more than a year or two, you're out of step with what's considered standard of care. But once I had said that once, they were like, well, Dr. So-and-so did it. I was like, I don't know who Dr. So-and-so is, but I haven't done a breast surgery in 4 or 5 years to any level that would be considered appropriate for the modern day woman. Plus, if something like breast surgery, you always can go to an expert. It's not an emergency to get it fixed 9 times out of 10. So that's the kind of feedback you get in rural medicine, though. It's like, well, why won't he do breast? I don't understand that. It's like, well,
Yeah. Now I want to go back to something you said. It opened my eyes to something. It's not about, like, your problem is you want to provide high quality care in everything you do. They just want you to do stuff, right? Like,
yes.
as a skilled surgeon, like, I'm sure you can do a gastric bypass, like, at a standard of care level of excellence. I can't because it's not something I do, but I mean, I could maybe get through it, I guess. But they don't care about that differentiation between doing something really, really well at a high level and just doing it and just having it done. And, like, I think that's the problem, right? Because like, you're in this uncomfortable position. You just wanna take good care of patients, and you know that something can be done, at a high level, and they don't care. They just want you to just do it.
Well, yeah, the other thing is too is let's go back to the breast for a minute. It's easier to do something like breast if you have a breast specialist somewhere in the system that you can refer to, like, "Hey, listen, I'm gonna do X. What do you think about that?" And rural medicine doesn't have that either. That's why you're doing it in the first place, because they didn't have that person. If they had that person would be busy doing it. And so you wind up venturing kind of blindly into things you know has whole levels of complexity that you aren't equipped for. And I think the problem with it is the problem with medicine in general is that people don't appreciate outside of medicine the complexity that has come with treatment. Meaning, like, the same condition has existed probably since civilization began, humans began, but the treatment algorithm only gets more complex as time goes on. And so, like you said, bypass surgery, like all the techniques and thoughts about that have just only increased in complexity as time goes on. And so it implies that somebody's got to know all of that to do it right. And the thing is, you could either be ignorant of the complexity or you could be so aware of it that you're like, I don't think I should be doing this. And I think that's the difference, right? Like that's the difference between the young and the old. Because the older surgeons, I hate to say it, but they have their worldview is based upon when they were in residency, and a lot of the things didn't have a whole lot of complexity to it. And so you feel comfortable dealing with it because it's not that complicated.
Being at a tertiary care academic center, I see a lot of like referrals from other places, and the complications I get from older surgeons are way more challenging to manage than younger surgeons. I mean, not to generalize, but in my experience, they'll take on crazy situations and do things that are crazy and like they're really hard and tough situations. And a younger surgeon would say, this is a hard, tough situation. You need to go to a specialist that does this. This is your fourth time around. I've seen patients who had 7 hernia repairs, and on the 8th try, the referring surgeon tries to be a hero, and it's always someone who's older in their practice, has been doing this for like 40 years and thinks that, it's just something you can fly by. And that, I think that's the mentality that these smaller hospitals have relied on, but it's not the way the modern surgeon thinks, right? We think that things should be done at a high level for everything. And if you're not someone that does it, you need to go see someone who does.
Yeah, exactly. I totally agree. I think discernment is a skill. And I think for really young surgeons, like surgeons in training, they have no discernment because they don't know what the capacity of what they are going to become is. So they're willing to do anything. They're like, yeah, man, we're about to do a brain transplant tomorrow. Oh, it's going to be great. I read about it in Mastery of Surgery. But once you get to, I would say year 2 or 3 of being out of residency, you start to realize this, I can make a living doing the things I know how to do. And the things I don't know how to do, I would really need somebody to guide me on that, or surgery would have to trend that direction. Like you said, bariatrics. You knew how to do bariatric surgery the moment you came out of fellowship, but after 2 or 3 years, you hadn't done a bariatric case. You just kind of let it go. And I think that discernment is important and key because once you get into the real world, you're not going to get any kind of like merit badges from doing more stuff. Like they're not going to do that. You're just going to take on more risk and have to learn what you're doing more. Like specialization is like kind of like a de facto way things work in today's age because that's just it seems more efficient and you seem to, be more efficient in what you do.
Yeah.
Rural medicine can't contend with that because they can't field a breast surgeon, a vascular surgeon, a general surgeon, or a bariatric surgeon, and a hernia specialist. They can't supply enough cases for all those people to justify their existence in that system. So I don't know
Yeah.
what the
So
solution is for that.
So I train a lot of residents, medical students who are into surgery, want to do it. Would you tell them to do it?
No.
To go back? If what?
No. I would not tell anybody to do general surgeon and be general surgery in this day and age. I would tell them to pick if they want to do a procedural specialty, to pick one that's so subspecialized that people understand that you're not here to do X, Y, and Z. I would actually, if you're interested, I would say ENT, where your level of expertise is in the name, or or GI, where or where everybody in medicine knows exactly what you will and won't do. Because what happens invariably is like, and then also don't pick anything that has emergencies in it. Emergencies are not worth it in medicine. Dealing with emergencies is just a surefire way to get sued and to get dissatisfied because people who come to the ED with a problem that could have been fixed in the office are always going to have worse outcomes than the people who would have gotten fixed in the office. And if that's part of your job, then your life is kind of be miserable. So, yeah, I would tell people to avoid general surgery. General surgery is a dying, or if it's not dying, dead subspecialty. I don't think anybody should be really pursuing it. But that's just me. I'm not in the educational part of it. Well, I
Yeah,
mean,
we'll cut that out in the post production.
well, no, so I will say this. I would say that what it is to be a general surgeon today is very amorphous. And maybe it always was, but it's amorphous in a bad way for the person who's practicing. Not knowing exactly, like, for instance, are amputations general surgery or they're not? Now, I feel like they're not, but a lot of people feel like they are. And the thing is, a lot of other people who do bones, ligaments, and everything else refer it off. Vascular surgery will say, "Oh, that's a general surgery problem, that amputation." Orthopedic surgery will say that's a general surgery problem. So what is general surgery? Because general surgery seems to me like it's doing all the surgeries nobody else wants to do at this point.
Yeah, that's a great way to describe it. And it's interesting because, I mean, I think this is a problem. It starts with training, because 50 years ago, you had maybe 50 years ago, you had literally one way of doing anything. So each thing you could be a general surgeon, right? There's one way to fix a
Mm,
hernia, you know, one or two breast operations really that people did, or treatment pathways. So, now taking examples of breast surgery, breast oncology, there's countless pathways, there's 30 different ways of fixing hernias. So now trainees don't finish being able to do all those things. They can do one or two of them, but that's not enough to be really good at X specialty part of general surgery.
yeah, no,
So
I agree. I think I don't know. Like I said, what would you tell somebody who wanted to be general? I mean, you do tell people this. So, what is your party line, and then what's your actual line?
Spruce, what would you tell someone who wants to do general surgery in this day and age?
It's demanding physically and mentally, but if you love solving problems with your hands, you'll probably find it deeply rewarding. Just make sure you're choosing it for you, not for expectations. Find mentors or folks who are living that life that you want and get their wisdom.
Empty platitudes from Spruce. And, it's funny because I'm currently mentoring a number of residents who are like towards the end of their training who want to do general surgery out in the country, far away from anywhere, like true rural surgery. We should get on a podcast with one of my partners, Dr. Manu Kaushik. I don't know if you met Manu, but he's super incredible human being in person, and he practiced rural surgery for a while in kind of the same environment you had, and has, the same challenges that you've talked about too. Because, I asked him because he counts himself as a general surgeon. He'll do anorectal surgery and colon surgery and hernia surgery and these things. But I mean, I think it's a real challenge. And if you're gonna do that pathway, I think early on in training, you really have to intentionally make your residency look like what your job is gonna want in the end. So
Yeah,
the resident that wants to practice surgery in rural Montana needs to learn how to do a C-section just as well as they know how to, like, take out an appendix, which is a true general surgery operation, right? Like, the number
well,
of residents who do C-sections is like something close to zero nationally, so
yeah.
we're not
Well, you
really.
know what? You know what? Despite Claude being sounding like a complete
It's Spruce.
Spruce,
Corey,
I'm sorry.
please.
I'm sorry. Spruce, elm, birch, whatever his name is. The thinking on your feet part is an interesting way of looking at it because there are two ways to think about procedures and being a surgeon. One of them is this thinking on your feet, almost like trauma in a way where you MacGyver a lot of situations because you don't know exactly what you're dealing with. And I'm not that kind of doctor, or I'm not that kind of thinker. I like the NASA way of like, here's what we're gonna do. Here's the book. And then if things are off book a little bit, you make it work, but this is the book. And my whole point is I don't know if general surgery is like that anymore because everything that's on book is a subspecialty now. Everything that has a book plan to it became a subspecialty to teach people how to use how to do X, Y, and Z the way X, Y, and Z should be done. Like for instance, the amount of vascular surgeries that old general surgeons know versus the amount of vascular surgeons that new general surgeons know is crazy. And the reason it is because vascular surgery stopped being cowboy. They started going endovascular and having a whole plan of action on everything. And they're not sitting by trauma bay looking for, you know, cases to do like that anymore. I think so. My whole thing is I think he's right that thinking on your feet, if you like that, then general surgery is for you. But you'll find out that most people don't like that because when you're thinking on your feet and it goes wrong, then you're sitting there like, "Oh, well, I thought that was the right move." It's like, "Nah, you should have known what the right move was. Don't go in a test. It's not a pop quiz, it's a dissertation, right? Like, don't go in there like flying by the seat of your pants. Know what the subject is and know how to do
Yeah.
it." But if you're
Yeah.
taking call, you take what you if you're taking call, especially rural medicine call, you take whatever comes in the door. Sometimes it's crazy. You might, see things you never seen before and be expected to take care of it because if you don't do it, it's not gonna happen.
Yeah. No, and especially if you go off book, like you said, then when you're wrong, the onus is only on you because
Yeah.
you made that decision independently. But yeah, when I think about planning, I mean, vascular surgery is so heavily intent on operative and technical planning and having a wide array of skills that you have to be a vascular surgeon to do. Like the idea, that vascular access is, and it's just something you can just do on the side is nonsense to me. Like
It's
that's a
total nonsense
that's a
because
technical skill you have to be good at, and like
it's
a
not
lot
only
of
a
rural
technical
places.
skill, but not only is it a technical skill, but the thinking behind these access points, the subtlety of that thinking, it happens for vascular surgeons so quickly. And most of these guys have a plan, but like I said, general surgeons not going to have a plan about it because it's only 15% of their practice or 10% of their practice or something like that.
What do you
But
think
even you, like
about?
what you do, you're doing complex hernias, right? You have a plan, right? Like you plan out these people.
Yeah, well, it's really funny because that situation happened just 2 days ago, fixing a hernia, and I realized that probably a better way was a different way, intraoperatively. And so I did this different way. Patient's doing great, everything's fantastic, and the resident was talking to me, and they want to understand all the ways I do hernias, and I was like, that's like my specialty. Like, if you want to do my specialty, that's great. Go do my specialty and learn to train. Like, no, I just want to be prepared. I'm like, that's not how this works. And I was actually thinking about our discussion about medical school and study. We throw out all the knowledge at you, but not everyone's going to know the Krebs cycle. I don't know why I always pick on the Krebs cycle. It's so specific.
Cause man, it's so convolutedly like complicated and like
So many
you realize
letters and
you know
numbers.
there's like 8 different chemical reactions you got to remember. And the thing about it is, it's funny because you don't really need to know them because if any one of those don't work in a person, they're dead at the DOA. Like they're never born in the first place. So it's kind of like a crazy. I mean, obviously it's knowledge and it should be learned, but it's like I don't know. But
Well,
Krebs
let me
cycle
ask you
does get a
this.
lot of hate.
Yeah, everybody hates except for my wife. She loves it, the geneticists. Well, let me ask you this. So, the current pathway for training surgeons is you got to do the whole training, you get your numbers, you have to do enough surgeries, and then you take a written exam to make sure you know all the stuff. And then that's the qualifying exam, and the certifying exam is the oral boards to figure out your judgment, decision making. I feel like that's all designed around what we were just talking about. As a true general surgeon, you have to be like iterative and work through problems and make sure you can figure out the situation. Does that make any sense anymore? Like, shouldn't you know the thing that you're going to do? Should we even stop? Should we take away general surgery boards? Or for even further, just end general surgery residency, do 2 or 3 years of general surgery, and then go down whatever pathway you want to be. That's been talked about for like since we were residents, like 20 years ago.
Like I said, I don't know where you go in the short term, but in the long term, I don't think there's going to be general surgeons. I think that's a throwaway term that's not going to make much sense. I think the fragmentation of general surgery is going to eventually lead to its demise because there won't be anybody who will be one. Because like I said, there will be a point where all general surgery is a collection of procedures and problems nobody else wants to claim. And once it becomes that, then it dies because nobody's going to want to train doing butt pus and things like that. Like if that's you know what I'm saying? Like that'll be the end of that. Like that's a perfect example, by the way. How is butt pus not a exclusively colorectal problem? They have somehow made it where they get all of the nuggets of colorectal surgery, and the butt pus is everybody's problem, or at least every general surgeon's problem.
Do you want to explain butt pus to the world?
Yeah, so butt pus is the human anus has these glands that get clogged a lot and they lead to abscess formations and they're very painful and they're also very common. They're not like there's no hygiene problem or anything, but they happen fairly frequently. And the treatment's fairly straightforward. You just lance it or you open it up, but it is a pain point because it's an emergency 9 times out of 10 too. So you have to drop whatever you're doing, or at least figure out how to work around putting somebody on the table sunny side up and doing an IND on them. And my whole point is every general surgeon knows about butt pus, and every general surgeon has dealt with it, but every general surgeon does not want that to be a part of their practice in any meaningful way. Even the ones who claim to be colorectal specialists, they don't want that to be part of their practice in any meaningful ways.
It's interesting because if you ask me to write down on a sheet of paper the number of operations that were general surgery, it's a dwindling list compared to 20, 30 years ago. You would
Yeah,
have said, oh yeah, a right hemicolectomy is general surgery. I don't know. Maybe some people think that taking out the easy part of your colon, I guess,
yeah.
but it's really just taking out gallbladders, appendix, hernias, easy hernias, maybe. I
Yeah,
don't
like
know.
I said, I think it's dwindling because the idea of a general surgery in a specialist world is an oxymoron, right?
Yeah.
Why do you need a
That,
generalist if you can subspecialize every portion of the human body or every procedure to a guy?
yeah. Or even
Um,
crazier is like if you're a patient, like why would you want to go to like if I have like a Maserati, I don't want to just take that to the rando mechanic around the corner. Like why don't I take someone who knows what they're doing with that thing? I don't know.
I don't know either. To me, it's about efficiency, right? Meaning, like any bariatric surgeon is more efficient at doing bariatric surgery than the world's greatest general surgeon or GI specialist, just because they know how to make it work and their staff knows how to make it work. Because some of this technique stuff goes beyond you, and that's what I learned too in a rural practice. It's like your staff, I mean, if you're, just because we're in the World Cup time, Lionel Messi on a bad team is not going to score any goals. Like it's just you need a guy. If you're the guy, and I'm not saying surgeons are the guy, but I'm just saying if you are the guy, you need a supporting staff that like knows how to do what you do or knows how to make you successful. And if that's not there, you will not be successful. Because if your instruments aren't cleaned, or if your patient isn't positioned right, or if the OR doesn't have the right lighting, or all kind of 100 different features aren't working, your quality can't help but to suffer. And
All
so,
right, should we get Spruce back in here? So I asked
well,
Spruce earlier,
why don't you say some things then?
what?
I don't know. I'm talking too much.
And you always talk too much. That's the whole nature of this podcast is you talking and me editing it down in post production. Spruce told me to spice it up the episode to do a little OR lightning round questions. You ready for this? It's not excited.
No.
Corey's getting tired of talking to me. This is the end of our podcast, everyone. We're done. Episode 7's good. Maybe this is a sign that we need to start getting guests. Maybe the next one we'll do a guest. What's the worst or music choice you could pick?
Do you what is your so I have an answer that I've seen be the worst one, but I don't know what the actual worst one is if I think about it, but I'll let you talk.
Well, tell your story first. I'll tell you mine.
So when I was in fellowship, my attending used to play the Hamilton soundtrack, which drove people absolutely crazy. They hated it. And you would play it and like sing along to it, and people absolutely hate it. So musicals are bad choices because most people hate musicals. The whole
All right.
idea is like people didn't like hearing somebody sing along a musical. That's just that
Yeah,
will
yeah. I mean, well, so that's different because no one wants to just hear the surgeon singing their little heart out like while everyone is standing around.
well, that's the
I'll
whole
tell you
point. That's what
what's the only thing worse than that is having a medical student in the room like sing their heart out, and everyone's wondering why is this person the one singing at the top of their lungs to Taylor Swift.
honestly,
Which, by
I've
the way,
heard
I think
the musical and Gregorian chants are both serious no-goes. The Gregorian chants were early on, like in the mid 2000s for me. Somebody put that on, and everybody was looking like he does
yeah.
this all the time.
I think for me, it's classical music. The best way to kill the vibes in the OR is put some classical music on. It is such a contrived, like obnoxious thing to do that like something that this is some kind of Picasso, experience for the world. And it's just so pretentious. Nobody likes classical music that much anymore. Let's be real. Because I think music choice is like, it's an egalitarian thing. You're doing it for everybody in the room. And if you put on classical music, that's just that's the middle finger to everybody who's there.
It truly is. It truly is. It rubs a lot of people the wrong way to have to listen to like Chopin for like 3 hours. Like, and it's
I
so
mean, I love
arresting too.
Chopin.
Cause
Don't get me wrong. It's incredible.
Chopin is the whole reason I say that about classical music. It's very much a single person consumption kind of thing, and it doesn't have a communal
Exactly.
feel to it. Like the best station to put it on is 80s, 90s, and today, because 80s, 90s, and today is like 50 years of music at this point. And so it's a potpourri of pop music that everybody can enjoy.
Yeah, see, that was a pretty good topic by Spruce, my man. We should have him. We should have him on the podcast more. See, I could tell you're getting a little antsy, a little stale talking to me. So I brought in Spruce. The next episode we'll get a human, maybe. A lot of these are stupid. I'm not even gonna waste everyone's time. Or we can do it and just cut out in the post production as usual. Most overrated surgical instrument?
Scalpel.
Wow, wild.
Scalpel's overrated.
That's a hot take, man. It's in the name. You can't say that.
That's why it's overrated, man. You could do any operation without a scalpel.
You would just use a bovie to get
You
make an
could.
incision?
You could. You asked about overrated instruments. I mean, I think either that. Listen,
I'm offended. I'm offended you're saying it, but at the same time, you're 100% correct. It is the most overrated surgical.
It's so overrated, dude. It's like the poster child of surgery, and it's completely unnecessary. You don't need it to do 90% of surgeries. Not even 90, 95%. With a bovie, you could do the same thing and more. The bovie is the most
weirdest thing. I
unsung
bet people don't
hero.
even know what a bovie is. A bovie is it's like a pencil that's attached to this electrical energies machine, and you just go, and it just burns and cuts at the same time. Yeah, that's wild. You just blew my mind. I like this game.
But the second most overrated, the most overrated for surgeons, the DeBakey's are pretty overrated.
I mean, come on, man. What
I know, that's why I said they're
now you
overrated.
lost me. The DeBakey, come on. It's a wonderful instrument. It's just a forceps for the people out there.
I didn't say it wasn't
it's a nice set of forceps.
I didn't say it wasn't a nice instrument. I said it's overrated. It's like, the Kim Kardashian of like instruments, because it's got the name brand and everybody's like, oh, hand me the DeBakey. It's like, dude, does it have to be a DeBakey? Just get a pickup, man. Like, it's such a
You're just
name
mad
drop.
about the name? You're just mad about Michael DeBakey?
Look, DeBakey's like the most famous surgeon of the 20th century, no doubt. I mean, and his instrument.
Yeah.
I said the most famous. Who's more famous than DeBakey from the 20th century?
Halstead. We talked about Halstead. He's more famous.
Is he, what years did he practice? I thought he was late 19th century.
It's both.
Okay.
He made his way in. Anyway, late 20th century, sure. Later.
So what do you think about your second? What's your second on the overrated list?
What? Oh, about the instrument? I don't know, because the most overrated instrument, like, I don't even think about it because I wouldn't use it, right? Am I thinking about that wrong?
Overrated means that it's thought about more than it's used, I guess, right? Or
yeah.
It's a claim is higher than it's used.
Yeah. No, I mean, you're right. I can't top scalpels. I'm a little mad at you about the DeBakey thing, but we'll pass
All
that.
right.
Some of this is dumb. It just gets dumber. Should we stop? Should this be the end of the episode?
We can keep going, man. What you got?
You like this game, huh? It just gets.
I do like it. I like games. It just
stops making sense though towards the end. Actually, if you could only perform every operation only robotically or only open, what would you do?
I guess only open.
Why?
Because, like, I don't know. Like, I guess for lack of a better way of putting it, when things go hairy in a robot surgery, you always know you got open to fall back on. And if you can't go,
see, this goes back to your kind of your analytical way of thinking. Like, see, I would just knee jerk say robotic with the expectation that everything's always going well, and then just do everything. So
they call that in engineering. They call that in software engineering the happy path, and it's the least common. It's the least common thought about path, even though it's the most common used path. The happy path is what they call it.
Wild.
But no, the reason I say that is because if you had a bleeder that you couldn't control robotically, and it got the camera done, I guess what are you doing? You calling that person that DOA? See, if you can't control a bleeder open, it can't be controlled. That's just it. It just couldn't be controlled. But in robots, there's a lot of little bleeders that'll completely ruin the field that you can't find. So, like I said, But I hate.
Yeah.
With that being said, though, as a minimally invasive surgeon, I hate doing cases open. Though I love doing them minimally invasively.
All right. Should we wrap it up? Should we have Spruce help do a little closure?
If you want
Hey,
to,
Spruce. Because, man, it's just, hey, my man Spruce, can you close out our podcast for us today in an interesting, funny way?
All right, picture this. And that's a wrap on another episode of Dueling Scalpels, the only show where sharp objects and sharper opinions collide. Remember, if you liked what you heard, tell a friend. Or even better, just scrub tech. If you didn't, well, that's a morbidity and mortality conference for next week. So next time, stay sharp, stay curious, and try not to leave any instruments behind.
God,